Hello everyone, this is Dr. J. In this video, we will discuss about how to manage anemia in patients with kidney disease. For many of you, these will be review for you, and I am not planning to spend too much time on this video. These are the objectives. Anemia is a complication of kidney disease. Anemia may develop as a result of inadequate erythropoietin synthesis. Patients may also develop early and worsens as CKD progresses. It may involve inadequate iron intake or impaired iron absorption as well. As you can see in the picture at the bottom, you can see that patients with anemia has significant decrease in red blood cells. Kidney act as oxygen sensors in the body, so renal tissue hypoxia triggers erythropoietin production. Erythropoietin stimulates erythrocyte, which is red blood cell, synthesis in bone marrow. Hemoglobin is the primary iron-containing protein in erythrocyte that transports and delivers oxygen to tissues. So it is very important to note that both erythropoietin and iron are required to produce hemoglobin and correct hypoxia in patients. As you can see in the diagram, cause of anemia in patients with CKD may be multifactorial. So you can see decrease in erythropoietin production, decrease in absorption of iron in GI tract, blood loss. So they go through a lot of blood draws, or especially patients with dialysis, they do 3 times a week. Every time they receive dialysis, it is estimated to lose blood. So why are we concerned about our patients with anemia? This is because anemia in CKD patients has been shown to be associated with morbidity and mortality, such as coronary artery disease, hospitalization for cardiac disease, death from congestive heart failure, all-cause mortality, and left ventricular hypertrophy. In order to diagnose and treat the patients with anemia, we measure hemoglobin, CBC, iron indices such as ferritin and TSAT. We also measure folate and vitamin B12 to correct their levels in case of macrocytic anemia. This table represents common signs and symptoms of anemia, as you should know. The patients with anemia, we usually see the complete blood cell count. TSAT and ferritin is highly utilized to assess iron status. You will have to know how to calculate TSAT for the exam. Also, it is critical to recognize that ferritin is not only iron storage, but also an acute phase reactant. This means that ferritin could increase if the patient has an inflammation. Please note that for CKD patients on dialysis, so HD stands for hemodialysis CKD, ND stands for non-dialysis CKD. The TSAT goal during ESA therapy, which we'll go over, ESA stands for erythropoietin stimulating agents. They're significantly higher than healthy patients. So ferritin for healthy adult will be 18 to 270, whereas for CKD patients, if they're on ESA therapy, it's typically higher than 500. Treatment goals are to reduce blood transfusion requirements, minimize hospitalizations, decrease signs and symptoms of anemia, and improve quality of life. Typically, the combination of iron therapy and ESA are utilized for anemia management for CKD patients. Iron therapy would be initiated when TSAT is less than or equal to 30% and or ferritin is less than or equal to 500 nanogram per milliliters. For CKD patients, they can start with oral iron therapy since they still have kidney function. However, patients on hemodialysis generally start IV form of iron due to lack of efficacy in oral formulation. Starting from this slide, many of the information should be a review for you from Dr. Hong's slides. Initially, many CKD patients receive supplemental oral iron. The amount of iron that's available varies by formulation. For example, a 325 milligram dose of ferrous sulfate has 65 milligram of elemental iron. This slide illustrates common side effects, drug-drug interactions with oral iron products, and monitoring parameters. GI symptoms are often limiting factor for patients to be adherent on oral iron therapy. When this occurs, you could consider starting with half of the recommended dose, then gradually increase. Or taking the iron with food or take it in divided doses are also another option. Food can lower the iron absorption, but some iron with food is better than none. Stool softeners may help for constipation because constipation is very common in patients taking iron supplements. What do we need to consider as pharmacists before starting oral iron? Whenever we consider starting any drugs, we should think about benefit versus risk, or pros and cons. The slide shows pros and cons about starting oral iron therapy. Oral iron would be a great treatment option because it is inexpensive, convenient because you don't have to visit clinic for the dose administration, and safety concerns are minimal compared to IV iron. However, GI side effects and limited bioavailability are the biggest cons. IV iron may be used in CKD patients more of advanced kidney disease. Indication would be intolerance to oral therapy, malabsorption, such as patients with IBD or gastric bypass, excessive continuing blood loss, um, cancer patients, or heart failure patients. This page is the summary of IV iron therapy. There are 5 different types of IV iron therapy in the United States. Again, this should be familiar to you. This page shows you pros and cons of IV iron use. There are several erythropoiesis stimulating agents available in the United States. The most commonly used is the recombinant erythropoietin. It's an injectable medication used since the late 80s. ESAs may potentially benefit patients, including reducing the need for transfusion. However, there is risk associated with their use, and it's required that all patients receiving ESAs be advised of the risks. Blood transfusions are associated with many risks. Patients required frequent blood transfusions before ESA were available. Blood transfusions has many risks, including volume overload, iron overload, allosensitization, transfusion reactions, and blood-borne infections. Anemia in dialysis patients is frequently treated with ESAs. The current role of ESAs for people with CKD is unclear. The FDA recently produced an advisory which suggested that ESAs not be used in CKD in patients with hemoglobin level over than 10. You should know these boxed warnings for the exams. This page illustrates what KDIGO, which is the guideline in nephrology, recommends for hemoglobin and CKD not on dialysis versus dialysis patients. As you can see, for non-dialysis CKD patients, you would initiate ESAs only if hemoglobin is less than 10 gram per deciliter. For dialysis patients, you use ESAs to avoid drop in hemoglobin to below 9, and you want the hemoglobin to be between 9 and 10. Both CKD patients and dialysis patients, you are not going to use ESAs when hemoglobin is above 11.5 grams per deciliter. In America, there are three types of ESAs. One is epoetin alpha. The brand name for epoetin alpha is Epogen and Procrit. So these are basically the same drug, whereas Epogen is only approved for patients with hemodialysis. Procrit is indicated for patients who are not on dialysis. As you can see, it's used more frequently compared to the others because of the shorter half-life. You can give the ESAs through IV versus or subcutaneous. So darbepoetin alpha RNS is used or it's given less frequently because of the longer half-life compared to epoetin alpha. The longest half-life for ESA is Mircera. Again, this should be a review for you. ESA, it commonly causes hypertension, infection, hypotension sometimes, nausea, diarrhea. What we need to monitor for sure when the patient is on ESA is hemoglobin, TSAT, and serum ferritin. So basic anemia indices or iron indices. A reasonable goal is an increase of 1 gram per deciliter in hemoglobin concentration within the first month of treatment. If the increase in hemoglobin concentration is excessive, meaning that more than 1 gram per deciliter over 2 weeks, the ESA dose should be reduced by 25% to 50%. As hemoglobin concentration increases, blood pressure response should be monitored because blood pressure will increase during treatment in some patients. There are numbers of factors which bear on the development of anemia in CKD. Not only is erythropoietin decreased, but there may be decrease in response to erythropoietin. This may result from uremia, chronic inflammation, hypoparathyroidism, or folate deficiency. Anemia is a complication of CKD. CKD patients can be treated with oral or IV iron therapy. Dialysis patients are usually treated with IV iron therapy. IV iron and ESAs should be used judiciously in patients with CKD. Consider potential reasons for hyporesponse that may facilitate dose reductions. Doses should be individualized. Consider patient's clinical status and the patient's desired outcome from the treatment. Thank you.